Hey, Rob, I feel like today's episode, there's so much we can cover. There's so many employees out there that are managing chronic disease and illness that has changed from 20 years ago to present. But today we're picking one. We're picking one that's really important. It's cancer in the workplace. So what do you think we're going to get out of this today?
Yeah, you're right, Caroline. And, we're fortunate. We're going to have two gentlemen with a ton of experience talking about chronic disease, drug costs in the workplace. And they've done a lot of collaboration together over the last 2 decades. Chris Bonnett and Allan Smofsky are going to be joining us today. And we're going to really focus on cancer in the workplace. And stats show that 40%, 40% of Canadian diagnoses are in the workplace age population. And 60% of cancer survivors return to work after cancer treatment, which is amazing. And cancer is one of those conditions that really affects the three areas of people's well-being that we talk about all the time in Benefits Alliance. And the three areas, that three-legged stool of their well-being, their physical, their mental, and their financial well-being. And you talk about an illness that has an impact on all three of those areas. And we're going to uncover that for our listeners today and also help plan sponsors maybe focus on a few key areas that they could start implementing right away in their organization. So excited to have them on.
Yeah, there's a education that needs to be done. We need to modernize a few things. And finally, collaboration is always key to help plan members and their families when they need it most. So let's bring them in. Chris Bonnett, let's start with you. If you can introduce yourself and give us a little bit of your background.
Sure, thanks. It's great to be involved with this because we've always looking for opportunities to work with plan sponsors, and more importantly, I think with plan advisors, and Benefits Alliances has been a great source and resource for that for some time for me. So I appreciate this opportunity to talk about cancer in the workplace. My background is about half of my career has been spent inside the group insurance industry in underwriting and sales management and product strategy, and the other half as an independent consultant focusing on health issues in the workplace, health strategy, and in more recent years in drug policy, particularly drug policy right at the interface of public and private drug plans. So things like rare disease strategies and national pharmacare, provider networks, all those things are my alley. And what I try to do is bring a practical bend and a fairly good academic background to bear on the problems that clients are facing.
That's great. And we've really enjoyed having you at our Benefits Alliance conferences, Chris, over the years, and really enjoyed your conversation. And also joining us today is Allan Smofsky. So, Allan, it's great to have you on. Thanks for taking time for us today, and give the audience a little bit of your background as well.
Thanks very much, Rob and Carolyn, and echoing Chris's thoughts about it's nice to be here. So my background is in some respects similar to Chris's, in some respects different. So I guess the fact that I'm from Montreal in and of itself, coming from the distinct society is a little bit different, but moved here over 25 years ago. And so my background originally was benefits consulting, worked for three of the major national benefits consulting firms. The move to Toronto for me was a move to focus more on prevention and disease management. Never really left the benefits field. It was just working at a different end of it. So I went to work for a little while for a pharmaceutical company that had a health management unit and focused, and their target market was the benefits market, which is why I got recruited to join it. Spent some time in that. So really since that time, the last number of years, I have been mostly independent, have aligned at different times with benefits advisors. I've worked independently pretty much across the spectrum, as Chris, with most stakeholders that are in the game of workplace health and benefits. Like Chris, do sort of benefits, strategy work. I've also been involved in workplace health and benefits initiatives. So implementing pilots, for example, in various disease management states, diabetes, asthma, and so forth, and then working on the evaluation of same. And the last thing I'll say is helping sometimes new entrants to this cluttered field, helping them understand the lay of the land, what the landscape looks like, which we all know is changing, and how best how they can make the best of it.
Well, that's great, and it's you both have collaborated on a couple of projects that I think is a topic that is so critical and important in today's workforce, and that is cancer in the workplace. And, according to some late Canadian Cancer Society stats, 40% of Canadians will develop cancer in their lifetime, and 25% of Canadians, unfortunately, will pass from cancer. And when we look at it, how this impacts so many organizations and so many people's lives. Talk to us what led you both down this path to collaborate on a number of kind of real unique collaborative papers and websites that you guys have developed.
Well, let me just start off that. And Allan, we will just go back and forth as we tend to. That's one of the advantages, I suppose, of working together all these years. I pretty much know what's in his mind, and he definitely sees what's in mine, and hasn't run away yet, which is a good thing.
Rob and I are working on that.
Caroline keeps trying to run away, so that's a problem. So we're going to get there sooner or later.
As long as you can't interpret each other's dreams.
We'll talk later, Rob.
Yeah. We're getting a little scary here. Fortunately, off topic, so I can bring it back. We just had the advantage, I guess, of knowing each other now for about 25 years. And at various points, we would get together, we would talk. And cancer looked like a really interesting area because it was becoming a chronic and episodic disease, not a fatal one, or not just a fatal one. It still is, obviously. We were starting to see information that suggested it was becoming a workplace issue. And not just a passive issue where somebody gets a cancer diagnosis, they go on LTD, and that's the last you ever see of them. But because of survivability, we're now seeing workplaces, employers, labor, having to work with cancer survivors. And with the costs of cancer drugs and cancer-related disabilities being top 5 across the board among all the carriers right now, it's an important cost. And it's also important because it doesn't stand alone. It very often is comorbid with other important conditions.
Yeah, one of the things to add to that is so the as Chris has kind of said, that cancer really wasn't an issue that most plan sponsors had to spend too much time thinking about. It was sad if you had an employee or member with cancer, but as often as not, perhaps more often than not, they would leave the workforce never to return, either because they were too sick and eventually they would pass away. And so there's a huge sea change in cancer, a lot of it due to newer treatments and advances in medicine, which enable, and most of us, if we haven't had cancer, we all know someone who has had it. I'll disclose that I have had cancer as well. And so I can add that to the work that Chris and I have done. I have now a patient experience. It was thyroid cancer in my case. And so cancer now, in addition to the survivorship issue, is in everyone's top 5 to 10 in drug spend, for example. And it's been for a long time number 3 or so in LTD claims. So it's still there, but it's there with a different face, and it takes on more. Now you've got a lot of employees who are able to return to work or even stay at work through treatment. But that's it poses its own set of challenges in the sense of someone who is going through chemo, for example, which fortunately I didn't, is literally from week to week and sometimes day to day, their ability to work may vary. And so that speaks to accommodation. So it speaks to a different dynamic. You're not losing your employees necessarily forever. They may come back or they may stay, but that poses its own set of challenges in terms of work scheduling and so forth.
Yeah.
I think, too, if I can add that one of the things that got really compelling as we started to get into our discussion paper a few years ago, which is on the cancerandwork.ca website, is this idea that a lot of cancer can be prevented. In fact, some of the more recent data that's come out is, I think it's about 36%, more than a third of all cancers are preventable with lifestyle behavior changes. Cancer is occupational as well. There are a number of carcinogens in the workplace that employers have to manage and collective bargaining tries to manage as well. Because it's preventable, because it's so prevalent, as you mentioned, 45% of Canadians will have a diagnosis in their lifetime. And because it's affecting younger and younger adults, it's really starting to impact productivity in the workplace. And it's very expensive, both on the drug side, increasingly on the drug side, because a lot of the pipeline work is aimed at specific rare cancers that come with very, very high price tags. So between the disability and the reserves and the monthly payments, plus the drug costs, it's expensive, it's preventable, it's highly prevalent, and it can be managed. And because, as Allan points out, it's now people stay with you after a cancer. There are so many more survivors in this country that it just is something that employers can no longer ignore.
Yeah. And when you talk about, 20 years ago even to now, right? Looking at the difference in both, treatment, success, prevention, survivability. When we think about who our audience is and talking to plan sponsors, what would you say that they need to know about today's world and helping to support their plan members when we talk specifically about cancer as a disease?
Well, one of the things they need to know, and Chris touched on it, is the fact that there is now some newer evidence that speaks to cancer at younger ages, and so we're seeing several studies now that are pointing to people getting cancer at younger ages. There's also an issue with more younger females being diagnosed, so it kind of flies in the face of what we, in some respects, have come to understand about cancer. In fact, Chris and I think we talked about that in our original paper. And again, that some cancers are decreasing in terms of prevalence, in part because of provincial screening programs. Think of breast cancer and prostate, to name two, which typically have been diagnosed at earlier stages. What some of these newer studies are starting to show is that A, it's younger people, and B, that at least in some cases, the cancer is being detected at a more advanced stage. And so you can understand or imagine at least the difference between someone being diagnosed at, say, stage 3 or 4 cancer, where it has spread and has you're sicker and everything else, as opposed to stage 1 or 2. So that is in and of itself is an issue. It's still newer learnings and still trying to understand what all that means, but it's there. The other thing I'll say about that is along with cancer at younger ages, is a number of cancers, 13 I think is the number, are related to obesity. And so, and don't have to tell this audience about the importance and of obesity nowadays with all the GLP-1s that are out there, and it's number 1 or number 2 on everyone's. So now that there are 13 cancers that are related to obesity, it speaks to Chris's point about needing to have a more multimorbid approach. So we can no longer look at cancer or look at obesity in isolation of everything else. Cancer also we know that about a third of cancer patients have a diagnosed mental health comorbidity, anxiety or depression. On top of that, there's another 15-20% of cancer patients that have, and not my term, but the studies show clinically relevant mental health conditions. So you're looking at about half of individuals with cancer with clinically significant or relevant mental health conditions, most of whom have been diagnosed. Of course, you think about the other half who maybe don't have clinically relevant mental health symptoms, but are stressed. So, Rob, you made a point about navigation. And so how can we support some of these individuals? Navigation is part of it, but, getting targeted information and the right resources to, right resource to the right person at the right time, some of which involves a multimorbid approach. Again, the individual who has clinically relevant mental health symptoms is stressed because they have cancer. Well, they also need some mental health support as well. That's not really how our system doesn't really lend itself very well to doing that. So that's an improvement that we really need to focus on.
Yeah, there's a lot of great points there, Allan, and you're absolutely right. It's that you have to be your own advocate more than ever. And when we talk in Benefits Alliance, of the kind of three-legged stool of people's well-being, their physical well-being, their mental well-being, and of course their financial well-being. And you can make an impact. All of that, as you just kind of mentioned, there's all 3 legs of that stool are impacted in a cancer situation. Maybe if we kind of unbundle all 3 of those one by one, and I'll put it to either of you to kind of speak to the point of how can plan sponsors help in those kind of 3 areas in your mind for employees that, or maybe not only just an employee, maybe if their spouse has been diagnosed with cancer or their child's been diagnosed with cancer, because, I'll take a lot of employee meetings and we can get into some strategies later, but we'll say if I got diagnosed with cancer, I'm like, you know what, I could deal with it. But if it happened to my spouse or child, my life changes dramatically instantly. So maybe kind of give the floor about around those 3 areas about what do you think in your mind are important strategies plan sponsors should start, or maybe if they wanted to create a policy of where they should start.
I can jump into one part of it anyway. I think back when I started in group insurance, I was an underwriter with Canada Life. In the ancient days, Pardon me?
No, I'm just kidding. So we won't hold that against you.
Yeah, okay. Well, I wasn't an actuary though, so it could have been worse. Um, but the thing that I was told right at the very beginning is the only thing that matters to plan sponsors was cost, cost. And beyond those three things, really nothing else hit. So I've already mentioned about cost at a plan sponsor level, the disability plans, the drug plans, the extended health, because people need more than just drugs. They will need counseling, as Allan's alluded to. They'll need help with probably physio and occupational therapy, things that are part of extended healthcare plans. But beyond that, there's been some interesting studies that have come out that have pointed at personal costs. One, the most recent one, came out from the Canadian Cancer Society, and some of its work, and I'm still trying to get that original study from them to read, is that they estimated about $33,000 was the added lifetime cost to a cancer patient, things that weren't covered by either their private or provincial health plans. So for a lot of people, obviously, that's a huge out-of-pocket cost, and it comes at a time when they're probably not working, or they're not working full time, or they're stressed, as Allan has pointed out, because this is a pretty emotional disease as well. And we can touch on the emotional side in a bit. The other study that came out that's really important, because it was Canadian, was based on a survey of 900 Canadian cancer patients. And it came up with roughly $2,500 per month for cancer patients in added costs, net of anything, again, reimbursed either by public or provincial or private health plans. And now about 2/3 of that was indirect costs. They lost time at work. They lost time for caregiving as well. And about 1/3 of that was direct out-of-pocket costs. That was $750, $800 a month. Now you've got to make more than that in order to pay for that. And you might get some of it back on your tax return from the medical expense tax credit, but you've got to come up with the money up front. And again, that's after everybody else has reimbursed you for whatever they're liable for. So these costs are a surprise to many people. People are off work, often for a year. They're not planning on that. And particularly as those diagnoses come earlier and earlier. I'll give you one quick stat from a study we've talked about being diagnosed at younger ages. There was one study, it was American, it looked at a couple of million cancer cases. It identified 34 different types of cancer. Now, 8 of those was the higher incidence for working age people than for people older than that, 8 of 34. And of those 8, 3 of them, that small intestine, renal, and pancreatic cancer, the incidence was 2 to 3 times higher for people born in the 1990 to 94 cohort than it was for people age 70 or older. So let me say that again, because it's a little bit mind-boggling for me. 3 of those conditions were more common in people in their 30s than there were people in their 70s, 80s, and 90s. So that's what we mean cancers working into younger populations. For other cancers in that group of 34, 9 of them were increasing faster in younger people while they had capped. They were no longer increasing in older people. So this is a real issue, and it's more incidence, more out-of-pocket cost, more emotional trauma. And I'll switch over to Allan because I'm sure he can deal with some of the emotional and physical aspects given some of his experience.
Yeah. So I think the couple of points I want to make before I do that. One is there's some areas like disability, which as long as I've been in this business, disability plans have, and if you look at this typical LTD contract, there have been some changes, but really not that many in the grand scheme of things. So helping people with cancer, to Chris's point, involves recognizing the notion of survivorship as we discussed before. So an example would be a partial disability clause in disability contracts, which, and you will know this, that typically the way it works is an individual has to first qualify for full benefits, and then they can subsequently potentially qualify for partial benefits. Well, given survivorship and given where treatments and medical advances have gone, many people will be somewhat disabled, but they will not be disabled enough to meet the definition of full disability, i.e. they won't qualify for disability benefits. So that comes back to the financial outlay that Chris talked about and all the stress that drives and so forth. In terms of the emotional aspect. And I have spoken publicly, and I will be speaking again shortly about my own story. I did not have anxiety or depression or anything like that. But there was cognitive dysfunction, while I was trying to work, and I'd have to read the same page 5 times over. And suddenly would, because I was told by the medical system, well, you're cancer free, you're good to go even after treatment. And so I would overpromise and underdeliver. I'd say, I think I can get you this report by Friday. And by Thursday, I'd have to make that phone call or write that email or whatever saying, I'm sorry, but I've got fatigue. I'm just not as performative as I have been. I will be speaking with an individual, I won't mention her name, but we will be speaking at a conference in the next while, who went through a similar journey, not my kind of cancer, it was a different kind of cancer, a fair bit younger than I am, and was actually diagnosed with depression. And so this individual's story is one of, and she worked for a major organization, provided all of the benefits that you can probably think of, from STD, LTD, navigation services, EAP, and on the list goes. I think it was 10 or 12,000 of mental health benefits, which, as you know, a lot of organizations have increased their mental health benefits. But the trick was, this was an individual who was diagnosed with depression. And so in that moment of high stress, being diagnosed with depression, certainly not fully anything close to fully functional, this was an individual who had to figure out for herself. So she had access to all of these things, but there was no coach, there was no resource that sort of pointed her from, you got this resource, which can lead you to that resource. She had to figure it all out for herself. Now, this is an individual who works in our space, who has some working knowledge of where to go. But imagine the plan member who doesn't have that knowledge, has the same degree of stress, and so you wonder why we don't get the outcomes that we could. Well, that's part of the problem. So, with a lot of these things in silos, it would be so much easier if, and I'll give you a quick example, if your first point of contact was, let's say, EAP or EFAP, to say, I've been told I have cancer, I'm stressed, which obviously this individual was. Well, EAP provided counseling. But what about connection to other resources provided by the employer? So we're not even talking about new money. This is all, these are all things that the plan sponsor is already providing and paying for. So it is a journey, and it's a journey that is perhaps not understood until you get into it. And when you get into it, you realize that the journey never really ends. There's a maze that we are going to be showing, which kind of depicts that. You're sort of entering it when you're, at a pre-diagnosis stage, and you arguably exit it when you're told you're cancer-free. But you're not really, because you're being followed by the system, and there's blood work, and there's this and that. So there's always something that's going on. So having those resources in place is great, but it's not good enough for most. There really needs to be some kind of coach, some kind of coordinating resource. Even we've got AI now. We should be able to do this fairly easily and just seamlessly point the individual in the direction of what the next resource is that we feel they could use.
Yeah, and first, Allan, congratulations for kicking cancer's ass. We're always like to just ring the bell from all the success stories you hear, and you're right, and this is critical no matter what size organization it is. For larger organizations, it might be tough. They might not know. Maybe an employee just keeps it kind of, they go off and they keep it pretty private, that they don't want somebody to know. And sometimes in smaller companies, that with 20, 40, 50 people, you'll know that so-and-so's been diagnosed and everybody's wishing he or she well. But sometimes that, employers might have that, what do I do philosophy. So maybe, from a benefit plan, where we have a lot of benefit plan decision makers that listen to our show, how about this, the value of a benefits program? I tell, when I got in the industry that, do I think people value benefit plans 25 years ago? Probably not. But you look in the last 4 or 5 years, like how much benefit plans have changed, with the rising costs and new medications coming to market, the number of specialty drugs, practitioners, wellness clinics have popped up like Tim Hortons on every other corner. And those costs are up, 20, 30%, depending on the practitioner over the last 4 or 5 years. Dental costs are a lot higher. So all employers are dealing with rising costs, but are there, important components? If this resonates with an HR manager right now that's listening to our podcast, what are some important areas that you think should be identified that people might not be aware of what's in or not in their contract when it comes to a cancer diagnosis?
Let me take a first kick at that. I think we've already talked about drugs a little bit, and we've talked about particularly high cost drugs that are coming to market or in some cases already in the market for rare cancers, which carry a price tag of $100,000 or more. So, one thing I think HR professionals need to do in concert with their benefit advisors and insurers is figure out the pooling and drug risk sharing mechanisms so that their plans aren't stung with these kinds of costs. Now, these are still rare cancers, and so it's not going to affect everybody. But if you lose that lottery as an employer, it's going to hit you hard, and it may be something that's extremely difficult for your plan to recover from financially. We're also seeing, I think, a lot of plans that are implementing annual maximums. Well, you've taken out the insurance risk from that, and this is all about insurance. This is why we got into insurance many, many years ago, is because you have an opportunity to help people that don't know they need help, that aren't expecting a problem. And there you are, whether it's health insurance, life insurance, fire insurance, auto insurance, it's all there to help you at an unforeseen time of need. And if cancer and other serious conditions aren't that, I don't know what is. So put the insurance back in place, check with your advisor around pooling and around risk sharing. I think there's a lot of advocacy that needs to be done around that to modernize risk sharing in the insurance industry. Think about critical illness. There's a kind of a benefit that actually kicks in and pays for a lot of those out-of-pocket, unexpected out-of-pocket costs that arise from cancer and other chronic diseases. Allan's already mentioned LTD and the need for partial and residual disability clauses. Those are things that sometimes are more technical than most employers want to get into, but advisors can certainly help in that space. Mm-hmm. And the last thing I'll say is that around when you have a cancer patient, and the research will indicate that about 60% or more want to come back to work. Work is not just a way to make some money, it's a social place. It's a place where people develop relationships, friendships, they have resources, they have supports there. In many cases, if they can be at work, they want to be at work. The thing that's a little different with cancer is that because it affects individuals differently, whatever your return to work protocol was last week, last month, last year for somebody may have to change fairly significantly for this cancer patient that's in front of you at this particular point in time, because their recovery, their reintegration into work, the supports they need, the accommodation you'll have to provide will depend on their age, the severity of the condition, comorbidities, their occupation. Blue collar don't fare as well often as some white collar. There's evidence on that. It's very individualized, and that's a real challenge for employers, particularly small ones, particularly if they've never seen a complex kind of claim like this before. So hats off to benefit advisors and benefits alliance advisors and member firms that can help employers with exactly those kinds of complexities at a point where they're throwing their hands up wondering, where do I go?
Yeah, right on. Music to my ears.
I want to ask Rob something because, Chris, I'm very glad that you raised the topic of critical illness, and not everyone knows exactly what that is or that it's available on benefits plans. So, while we certainly don't want to position this as a sales opportunity, it's actually a control opportunity. As an individual who gets cancer, in any of the areas that they're trying to navigate, whether it's the benefits plan or provincial or otherwise, at the end of the day, you mentioned not everything is covered, and that the average cost being over $30,000. So there is something that can be put in place for all employees and their families with a conversation with the advisor to weigh that out, because what a gift at a time when you need it most. There is a check for $10,000, $20,000, $50,000, whatever it might be, and you don't even need it to be approved with a claim specific item. It is in your control. It is a check that comes to you, just like life insurance, to gain control and navigate how you want to spend that money. So that's my preface to ask Rob a question is, do you feel like that there is more awareness and availability among plan sponsors of critical illness insurance and looking at implementing that? I'd love to hear your perspective there.
Yeah, the answer is yes. You're absolutely right. So when we talk about modernizing benefits, this is a perfect one. When the stats show that 40% of cancer diagnoses are in the working population. So let's think about that. if you've got 100 employees, that's 40 members or 40 spouses that are going to be could be by this diagnosis. And cancer is so many different things. It's just not like one disease. It could be so many different formations, and affects everybody differently. And as you said, like life insurance, obviously, if I, as an employee, I wouldn't see it. Like my family would see that life insurance, but the importance of premature death and then of long-term disability. I can't work for 4, 5, 10 years, my rest of my working career. That's the importance of having a long-term disability benefit. But it's a living benefit. It's the importance of that. It gives you that tax-free amount of money that I can do whatever I want with that income. And Chris made a great point, and Allan, talking about residual disability definitions. Not many insurers offer it. Talk to your advisor about what residual definition is. But you're right. You could have an individual, an employee that never becomes eligible for long-term disability because they're not totally disabled during the waiting period. And I've got clients, I've had friends, unfortunately, that have been diagnosed with cancer where they might have been off for 2 weeks after doing chemo because they felt awful. And then they wanted to get back to work. Some of these individuals were business owners, so they didn't want to be off that whole time, unfortunately, obviously. And so they're off for 2 weeks, back to work for 2 weeks, off for 2 weeks, back for 2 weeks. This diagnosis could go on for a couple of years. That person's not eligible if your contract is a total disability benefit because they're not off for the majority of the time during that, say, 120-day waiting period. So the critical illness gives that lump sum tax-free amount of money. It could cost as little as a couple dollars a week, depending on the carrier, depending on the contract, for $25,000 of coverage, as an example. And what I've always said to employers, I'm thinking how long it takes somebody to make $25,000 after tax. And, with some of the stats we talked about today, it can be life-changing for individuals. And, as Allan and Chris have referenced, and I do advise people to go look at the cancerandwork.ca email that these two gentlemen created, is that you look at those the three-legged stool we talked about. Like it's the physical impact, of course, by going through the disease and going through depending on their medical treatment that's required, the mental impact of emotionally potentially having to, from a depression standpoint and off work and stress. And then because most of all that financial impact is, unfortunately, most people are out of pocket, potentially during a cancer diagnosis. And I'd love to touch on this. We've touched on it a bit. And I think it'd be surprising for people to know, like, wait, the government's not going to pay for it? We're based here in Ontario, and it varies by province to province. And, maybe I'll as kind of the next question back for Allan and Chris, why don't you touch on a bit like how drug coverage, first of all, what are the options, because there's inpatient or outpatient, and then two, how does it vary by province potentially about how someone could get reimbursed for one of these medications?
I'll start off on that one, and Chris will, I'm sure, want to chime in on that. I think so as you've said, Rob, drug coverage this is Canada, and so we've got, 10 provinces and 3 territories, and each has its own drug formulary and way of doing things. And so how cancer is treated, if you live in BC, you're treated a lot better under the public health system than if you live, let's say, here in Ontario. So it is a bit of a lottery, and that is a challenge for plan sponsors and advisors for sure, but it is what it is. So I think the definitions, and that is where some of the challenges have occurred, that, traditionally a lot of cancer medications were dispensed in hospital. There was no debate about whether or not they would be covered. They were dispensed in hospital, therefore covered. As we all know, many medications now are either oral or they're injectables, but you're doing it as an outpatient. And so it's a different dynamic. And there's the question, at least in the minds of some, as to, okay, well, is that, who should be paying for that? But the reality is it's no longer under the hospital budget. And so how do we deal with that? So that's part of the problem there. And that is something that, again, it varies by province, because certain drugs are going to be covered by province, even as an outpatient, and other drugs and other provinces won't. So that's one issue around that. I think I just want to come back to the pooling question for a moment, because I was reminded as I was listening to Chris and you, Rob. I remember being at a conference a number of years, not that many. I mean, it might have been pre-COVID, but it would have been just pre-COVID. And maybe it was even since then. And there was an individual who spoke, and he was speaking about a plan sponsor. This was a benefits advisor who talked about a plan sponsor in a meeting that he had had with the CFO and HR individual of that organization. And they were talking about pooling points. And I think part of it was because the insurer had, not surprisingly, had come forward with, we're going to now offer you the same protection at higher cost, or less protection at higher cost, whatever it is, but it's going to cost more and you're going to have to take on more risk. And the CFO made an interesting comment because they were looking at it as a $10,000 pooling limit. And I think there was some question of maybe going to 20. The CFO said, well, we have a $1,000 limit on our fire and P&C insurance. Why wouldn't we just apply that, to drug claims? We're willing to take on that risk for some, it's different because you're talking about it, per individual or what have you, but it was an interesting way of looking at it. And so it comes back to the value proposition and what we're willing to pay. So I think the drug question is key. We have heard, for example, from pharma companies about there are a lot of drugs in the cancer space that are possibly likely to be approved eventually by provincial governments, but it takes some time. And so they've talked about a 12, 18, 24-month window where they say, look, the drug is approved by Health Canada. It's out there in the market. These are drugs that would benefit patients, keep them at work, et cetera, but they won't likely be covered by a province for some time. Would private plan sponsors be willing to cover it? And the issue is, on one level, it makes sense perhaps because you're providing medication to your employees, but I don't know many plan sponsors, if any, who want to, after 18 months, go back to do something on an interim basis and then have to go back to the membership and say, well, sorry, we thought it was going to be covered by the province. Now the province has said no, so we're going to take it off the formulary. So it's a tough discussion, and yet you've got people who need these drugs for, and this is, you're not talking about a few weeks, you're talking about, the better part of a couple of years. So that's a dilemma that we're going to have to deal with, is what to do with these drugs. It comes back to the value question that I think Chris raised a little bit earlier, is what is the value of providing benefits, in this example, drug benefits in particular? What are we willing to pay for and cover, and under what conditions? And I think we have to rethink that whole, it goes hand in hand with the pooling discussion.
Yeah, I think there's real challenges in the employer space. Back in the day, let's say 25 years ago, when the first biologic drugs were coming along, and they were a whopping $20,000 or $25,000. And I remember everybody sort of throwing their hands up, like, could it possibly get worse than this? Yes, it is. It's 10 times and 100 times worse than that in certain specific cases. Some of these once administered therapies are well over $2 million, sometimes $2.5 million for a one-time administration. Now, they might come with some kind of guarantee of efficacy, but from the manufacturer, but maybe not. So there's a lot of potential shocks to an employer related to a patient with cancer. And so on one hand, you've got the financial side of their brain ticking over and overtime, thinking, well, I've got drug costs, I've got disability costs, I've got communication costs, and this is a shock. And on the other hand, it's empathy. What is this person going through? How on earth are they coping with all this? As an HR manager, as a colleague, I might know some of their family. I might wonder how on earth they're financially affording this if their wages aren't high. Remember, in group, we have one size fits all typically. It's the same 80% reimbursement, the same deductibles, whether you're making $150,000 or $50,000. That's something I think employers and insurers and benefits advisors need to wrestle with in coming periods. If you can't do everything for everyone, then how do you allocate the available dollars and supports so that perhaps the people that need them the most get the most? Yeah. Now, there's a great philosophical question for a whole other webcast, because that's a real challenge for people to get around, particularly in collectively bargained environments. But it's one I think we have to face if we can't do everything for everyone. Yeah. The other point that I think is really, really important and a real opportunity for employers, insurers, advisors is kind of forewarning plan sponsors about what's going on. And that requires a whole lot better reporting. If all you're getting as an employer is the top 25 drugs, so what? You can't pronounce half the names. And those come and they go, and some are chronic and some are acute. But what you might want to know is what kinds of conditions are those drugs treating? And how is your drug plan connected to your sick leave or absence program, your short-term, long-term disability, in terms of the health conditions that are driving those costs? That would apply to critical illness if you had it. It might also apply to a workers' comp if you had it and knew the occupational conditions that were also driving your health-related costs. All of those things are rarely packaged. And yet that's the kind of early warning system that in an increasingly sophisticated and complex market that more plan sponsors may want to see. And again, that's a tremendous opportunity for advisors and insurers to work together to figure out what's going on in a plan and to allow a plan sponsor also to benchmark their own experience against other companies in the same industry, companies of the same size, in the same province. That kind of help is more and more necessary just to take the shocks and surprises out of the system if possible, or at least minimize or mitigate them if you can.
Yeah, I think there was so much that has come through that. And I know as we look, I think where I want to round things out as we come to the close of this podcast, and I agree with you, we could do a whole other episode and carry on. But I think as we close things off and wrap things up, from a plan sponsor and advisor and provider perspective, I think that collaboration is key. Like you said, how do we help come together and just simply drive that education and awareness? Because let's face it, people are not reading their booklets still, no matter whether we have them online or paper, until something happens, right? And what I've learned from the proactive, I'll say, mental health and wellness providers is picking something that is people can relate to in providing education, right? Did you know if you get cancer or get a chronic disease, here is some mental health and wellness support available for you. Here's how this works. So it's kind of educating people at a time when something is not happening, so that when it does happen, it rings that bell in their mind that, okay, I remember this, there is a resource, and how can I navigate this? So when we think about that on collaboration, is there any best practice advice that either you, Rob, as an advisor, or Allan, Chris, that you have navigating this industry that you would offer to employers?
Yeah, I'll start that one. So I think that is one of the key themes that Chris and I have uncovered. It's not like we didn't know this before, but it's interesting when you do the work and you look at the possibilities and you look at the gaps. We actually wrote, as part of one of our reports, was actually called a gap analysis, because there were so many obvious gaps in the system. So I think I'm really glad, Carolyn, you've asked that question around collaboration. The reality is that, and I think there's growing awareness of this, is that to do it right, you talked about best practices, you cannot do it without collaboration. And so from the plan sponsor and advisor perspective, they don't have the resources for the most part to do it, but they have to lead the charge. And so the role for the plan sponsor and advisor is really to say, okay, what are our top health issues? And let's say cancer is an issue. Let's call in some of our key vendors. Let's bring in the insurer. Let's bring in the FAP. Let's bring in the virtual platform provider and anybody else that, will touch our members when they have cancer, and just sit in a room. And just that dynamic is so out of the box for so many, but just that dynamic alone of bringing stakeholders together. I worked with, I've worked with lots of organizations, large and small, but I remember one in particular, fairly large organization. And it was around smoking cessation, so not directly related to cancer. And they had a vision of what they wanted to do. And they called in their insurer and their EAP provider, and they said, this is what we want to do. And both parties said, no, we can't do it that way. Through discussion, no became a partial yes. It was, okay, this was important. So it's, the plan sponsor and advisor have a critical role here to bring the others together to say, we have a problem. You're all in this with us. We need to work together on doing this. There are a couple of points around that. And part of it, I think, is there's a lot of low-hanging fruit. So when we talk about putting resources together, the story of my colleague that I spoke about and her journey, if you take a simple example and we look at someone who, what are those teachable moments where an individual is arguably ready to receive information, ready perhaps to make a change? Well, A time of diagnosis would be one, but it's sometimes difficult to get, to the doctor. Another one would be if you're prescribed a medication and you go to the pharmacy to pick it up. There's a built-in opportunity right there to use the PBM, or ensure, as the case may be, to connect or at least make a resource available. Some of the pharmacies are doing that through, chronic disease coaching and so forth, but connection to EAP. I know in the US there's at least one large EAP provider that works with that, and they have built a connection back to the drug plan where it's exactly that dynamic. So you show up, you're diagnosed with, pick any chronic condition, doesn't have to be cancer, and you show up and there's a flag in the system. And so the conversation, I suppose, I haven't seen it in action from the pharmacist, is, oh, we see that your plan covers this. Would you like us to connect you? Or here's, it's recommended, whatever the wording is, that you contact DFAP. Just that would have helped my colleague, for example, on her journey. And that should be low-hanging fruit. And so there's lots of other things that we can do to put resources together. But it starts in some respects with the plan sponsors and advisors, because you are the ones who pay the freight. And frankly, I think when I hear plan sponsors or advisors say, well, it's the vendors that have to innovate, they're going to innovate if you insist that they innovate, and they're not going to innovate so quickly if you don't. So it's on you, at least to start.
That's great. That's a great point, Allan. I'll jump in real quick, and Kristen, I'll give you the final word. I'll say, it's also critical to be proactive instead of reactive. Most of the time, benefit discussions are reactive. Rates gone up. What do we do? Right? Do we have to look at somebody else? We've had all these claims. Now, what do we do? Being proactive discussions is more critical than ever if you're a benefit advisor, because the landscape's changed dramatically over the last 4 or 5 years. And if employers haven't looked at kind of proactively managing their plan the last 3 years, or modernizing their plan the last 3 years, I can tell you're behind your competition. And you can't buy fire insurance when your house is on fire. So the importance of kind of looking at some of these strategies is critical before it's not if, it's when, you're going to have this a situation in your workforce. So Chris? Final thoughts?
Let me just add to that and just say, it's not just, being proactive for those more general kinds of duties and responsibilities, but also being proactive with health related data and having some insight on what's going on with your workforce. I was part of the Sanofi Healthcare Survey Advisory Board for many, many years. And one of the recurrent, really interesting findings, it was repeated several times, was that employers generally had no idea how much chronic disease had been diagnosed among their plan members. To give you a representative example, if employers, you ask them and they said, well, we think about 30% of our workforce has a chronic disease diagnosed, not just, imaginary, diagnosed by a physician. And you would talk to a workforce, it would be twice that. It would be roughly 60%.
Wow.
So if you if you don't have the data to understand how often your people are affected by health, chronic, comorbid, several conditions, which make life a whole lot more difficult, and you're just going to be surprised when these situations come. So having the data, having this sense of being ahead of the curve a little bit is important. Remembering that it's education, Carolyn, as you said, being proactive, here's information you need at the right point in time, but also remembering there's a ton of work that needs to be done around behavior. So if we want to prevent cancers, as we said, roughly 30%, 36% are related to lifestyle. So we need to continue to look at those fundamentals: diet, exercise, exposure to sun, smoking. And guess what? The benefit is that you're not only going to prevent cancer, you're going to prevent a number of other chronic disease, or at least mitigate those diseases or take them off into the far distant future. So there's a lot of things that can be done that will benefit cancer. Maybe our point today is try to highlight cancer as one of the important chronic and episodic diseases among your workforce, but also link that to all of those other chronic diseases that will benefit from being proactive, looking at the kind of high quality education and looking at readiness to change, which is the whole behavior element that also has to be seriously considered. We've made a lot of progress. There's a long way to go yet.
And again, your website is cancerandwork.ca that Kristen.
Yeah, Rob, let me just point out, it's a website that Allan and I have been benefited by having some of our work published on. That website is co-sponsored by the BC Cancer Agency and the School of Nursing at McGill University. We support them, we promote them, we talk about them because they're a unique Canadian resource, and we know the principles involved there. but it's not ours. We just get
Oh,
lucky
that's
enough to have some of our work put on it.
Well, we're grateful you have been putting work on there. So it's just for everybody to resource. And we want to really thank you for joining us today at the on the Benefits Alliance Voice. And I think there's lots of discussions, Caroline, we could have with these two very knowledgeable gentlemen in the future. So maybe we'll have them back at another podcast.
Wonderful. Thank you both for joining us, Allan and Chris.
Our
Happy
pleasure.
to. Thanks very much for the opportunity.
Absolutely.
Thank you for joining us today at the Benefits Alliance Voice podcast. Please subscribe wherever you get your podcasts. And we look forward to you listening to future podcasts. And if you feel this would be valuable for one of your colleagues, please feel free to share.